what I'd like to do, and I do heed the admonition to stick within an hour, I only have about 35 slides or so I'd like to get done with them in about 40 minutes or so, and then have the rest of the time to take questions and entertain questions from the audience, and actually have a discussion about going forward how Medicaid can actually achieve the objective for which it was intended, especially given the dramatic changes that are going to be occurring in Medicaid beginning 2014. My talk, however, is confined primarily to children in the child welfare system. I'm going to be talking about them as children in child welfare going forward. I'm interested primarily in the use of Medicaid as an instrumental mechanism to achieve certain broader goals of interest to health services researchers, such as access and quality. And so some of this, since it is an overview of my work, may be old hat to some of those of you in the audience or from the Brown School. So feel free to take a nap and but as a courtesy to your colleagues, please don't snore. But the latter part of my talk, I'm going to focus on some newer work that we are on the cusp of getting funded for, and so hopefully that will wake you up. So I'd like to begin with my favorite study ever. Now, I think epidemiologists are really cool people. And this study was published in BMJ, British Medical Journal, in 1992. This is the Glasgow necropolis, the cemetery outside of Glasgow Cathedral. In fact, there is even a Friends of Glasgow necropolis for people who cannot wait to get here. In 92, 4 British epidemiologists decided that they would actually investigate the relationship between socioeconomic status and mortality or longevity by measuring the height of these obelisks, which in Victorian England were used which were constructed over people's graves, by sort of measuring the height of these obelisks and actually relating it to the age at death of the person who was resting beneath it. And they surveyed about 8 different graveyards in the greater Glasgow area and looked at all burials that occurred between 1850 and 1920, when this practice ceased for some obscure reason. And they found, and so you can probably see that this person is, well-to-do. This person is obscenely wealthy. Right? Or arrogant. Or narcissistic. But they looked at these relationships and actually found that every meter increase in the height of this obelisk was actually associated with a 1.8-year increase in age at death of the person who was resting beneath it. And so established in a very unique way, really, the relationship between wealth, at least at the time of death, and longevity. Now, the antecedent, since then, we've actually understood the relationship between wealth and well-being. In fact, my grandmother used to say, eat your broccoli, health is wealth. Actually, now that we know the literature, I can correct my grandmother. Actually, wealth is health, right? And now the reason why being poor is injurious to your health is very complex, those interrelationships.
Just as a side note, and for the audience, there is a similar thing with education.
Mm-hmm.
Similar reverse relationships that is we're only starting to look at.
Right, and Heckman has a very interesting...
It's not education, it's wealth, but wealth is education. Anyway, keep going.
Right. And so the reason why what is it about poverty, about disadvantage that affects well-being is really unclear. It could be several things. It could be social class, which is basically social stratification based on occupation. It could be social status, which in some sense is the societal reflection of that occupational status in terms of social prestige. Or it could simply be income, and there is actually evidence for all 3 of these. The effects are actually heterogeneous. We know that there are positive income gradients for certain conditions, like autism, for example, which is consistently documented among individuals who belong to a higher socioeconomic, of children of individuals who belong to a higher socioeconomic status. And there are also negative income effects. We know that, for example, schizophrenia is more common in individuals of low socioeconomic status than in individuals of higher socioeconomic status.
Autism is more common in higher?
Yes. Yes, so there are both positive and negative income gradients. And these income gradients apply to some diseases but not to others. So we know that there are income gradients for diabetes, but there are not significant income gradients for cardiovascular disease. So what that is those effects are quite heterogeneous. And we know that the mechanisms are still being studied. It's possible that the wealthier you are, the greater access you have to foods that are of higher nutritional status, like the foods that Nora is eating right there. It's possible that the wealthier you are, the less exposure you have to toxins, substances, and other risky behaviors. It's possible that the wealthier you are, you have the greater ability to control and manage risks which are part of the inevitable vicissitudes that life throws at us. And it's possible that the wealthier you are, that actually affects your genetic expression and gene expressivity. So, and finally, it's possible that the wealthier you are, the greater your access to healthcare services. And as a services researcher, that really is my starting point for this talk. So the question that I'm going to pose to you, this is my research agenda, this is what I sort of grapple with on a daily basis, is how can we actually reduce the effects of childhood disadvantage upon mental health inequalities? And I study children in the child welfare system, perhaps the most disadvantaged of all child populations. The process is primarily by increasing access to and quality of mental health services. So that's the process by which I think we can actually achieve this goal. And the instrument that I'm primarily interested in is that of Medicaid policy. And because many of you may not be services researchers, this is how those of us who are services researchers think about the world. Consider a population of all kids. Some of these kids will develop mental illnesses. Some of those will actually begin to use services. We think about a fifth of those. And of those who use services, about a third will actually achieve recovery. The pathway that leads from all kids to kids with mental illness is the pathway that we really want to break, and that's called prevention. The pathway that leads from kids with mental illness to kids using services is the pathway we actually want to promote, and that's called access. And the pathway from kids using services to kids achieving recovery is also the pathway that we want to promote, and that's called quality. Because ultimately, a high-quality intervention is that which, when appropriately deployed, increases the probability that someone will get better. And this is the research agenda of mine that I'd like to walk you through very briefly today. I'm going to first talk about access to services, and I'm going to be talking about key findings from two studies funded by ARC and HHS, the Administration for Children and Families, which collectively examine, is access the issue? Are there systemic problems with Medicaid policy that impedes access to mental health services for child welfare populations? And at the end of that, I'm going to say that the answer is actually no. That there may be individual determinants that preclude access to services. There don't seem to be any systemic policy determinants that seem to preclude access to services. At least, there don't seem to be any elements that Medicaid policymaking that are mutable through Medicaid policymaking. So I then turn my attention to quality. And I'm going to ask, is poor access to poor quality care the reason why children in the child welfare system actually exhibit these mental health inequalities? And I'm going to look at quality from a variety of different perspectives. Quality as clinical appropriateness, quality as deviations from national standards, quality as geographic variations, and Gyanish Lama and I have a paper that I'll show you about. And using all of these, I'm actually going to tell you that yes, in fact, the reason why we see these mental health inequalities in kids in child welfare is fundamentally because of quality. And which leads us to the question of how can Medicaid improve quality? And I'm going to end by I'm not going to talk very much about paying for the costs of implementation, since my eye is on that clock there, but I will talk very briefly about two recent studies that are on the cusp of getting funded. We would have gotten funded but for the delay in the federal budget. The ARC study, which attempts to do a better job than has been done before on quantifying the expenditures that Medicaid incurs on children in child welfare, and I'll show you some of our preliminary data in a paper that we're getting out shortly. And I'll also talk about race ethnic disparities and how Medicaid policies can inadvertently worsen race ethnic disparities among this population. And when you think about it, I tend to think of disparities also as a sentinel of quality. Insofar as we don't really want to see disparities, we really don't want to see differential rates of service utilization as a function of anything other than clinical need. And so if we do see that, that per se suggests a quality problem in the health system. And so to a services researcher, a disparity is a quality issue. And some of you who are quality researchers may disagree with me, and I'd be happy to engage in some arm wrestling. So, talking about access to services. So I've used a variety of data, but the data that I'm going to share with you today are primarily data from the National Survey of Children in Child and Adolescent Wellbeing. NSCOR, as we abbreviately refer to it as, is a nationally representative panel survey of children who come into contact with child welfare agencies. The first wave was fielded 1999 through 2000, end of 2000, and then there's a 12-month, an 18-month, 36-month, a 48-month follow-up waves, and now there is a second wave of NSCORE also out in the field. NSCORE captures all children and adolescents, birth to age 14, coming into contact with child welfare agencies in something like 97 primary sampling units nationwide.
What's the control group here?
It's a national survey. It doesn't have a control group. It's an observational study design.
But you're saying they're only surveying those who have come
into contact with child welfare agencies, who are investigated for maltreatment, abuse, or neglect.
Okay, but that's already a very specific group of people.
Yes, so the reason I focus on child welfare kids is among all the populations of children in child welfare have the highest rates of mental health service utilization and expenditures. They have among all child populations, children in child welfare are the dominant child users of mental health care services. So anyone interested in child mental health, like when I was a resident, when I was a fellow, I would see children in child welfare all the time, children in foster care all the time. Over half of my caseload was kids in foster care, which is actually what got me interested in the mental health needs of these kids. So we also have, we've also linked policy data from a study called Caring for Children in Child Welfare, which has policy data at the county level of all of the primary sampling units that were surveyed in NSCORE. And so this study is actually a companion study to this, was funded by NIMH. We also have area resource file, which has a whole area, which has a lot of health resources information collected at the level of a county, which we've also managed to link to these data sets. And so we finally created a multi-level panel data set with individual children clustered within counties and county policy regimes that are followed up over time. And in this case, I'm going to present some survey-weighted logic models and some predictive margins for variables of interest, and I have these citations at the bottom of most of my slides, so you're welcome to follow up afterwards. And in the interest of time, I'm only going to show you these contextual results. So controlling for individual level characteristics, controlling for child characteristics, caregiver characteristics, caseworker characteristics, we find that children who are actually in behavioral carve-outs, which is actually a type of Medicaid financing arrangement, where the mental health benefit is separated from the physical health benefit and is contracted for and is paid for separately. Children who are in those sorts of behavioral carve-outs actually have a reduced inpatient mental health services use, controlling for need. And we also see certain other characteristics that primarily relate to availability of healthcare resources. So places where there is counties where there is an increased ratio of child psychiatrists seem to see an increased ambulatory service use. And this is consistent. Those of you who read Weinberg and are interested in large area and small area analyses know that this is probably reflective of some supply-reduced demand. Places where there is an increased ratio of pediatricians are also associated with a decreased ambulatory use, as also decreased inpatient use, which suggests to us that there is probably some sort of a competition going on for the child mental health marketplace between pediatricians and child psychiatrists. Pediatricians, as you probably know, outnumber child psychiatrists between 7 to 1 and 22 to 1, depending upon where they're actually located. But this is what sort of really interested us, the idea that structural mechanisms within Medicaid can actually have an impact upon service use controlling for need. And we developed predictive margins for this, and we found that if you had a county that previously did not carve out its services, but then began carving out its services, the probability, the relative risk basically, that the child in child welfare controlling for socio-demographic characteristics and need would actually access inpatient services fell by about 53%. So controlling for everything else in the study, just the fact of changing a particular way of financing and structuring services can have fairly profound effects on at least inpatient mental health service use. And we found there wasn't much of a difference on ambulatory service use. And these effects have been shown for other child welfare populations. When we began, although these are adjusted for need, when we did begin to stratify populations based upon mental health status, we actually found that there didn't seem to be an inappropriate suppression of inpatient care. In other words, what seemed to be happening was that these carve-out mechanisms were perhaps appropriately channeling kids from an inpatient environment to an outpatient environment, and was also associated with increases in medication use. And so probably this is not necessarily indicative of poor access. We Now, clearly, you could say that access is only conditional upon having Medicaid. So, in other words, Medicaid policy can only act if you know that someone is on Medicaid, although there are some positive and externalities that we can certainly discuss. And since there was very little understanding of the longitudinal trajectory of maintenance of insurance coverage over these children, we actually did a study to see what happens to insurance coverage over time. Does Medicaid actually do a good job? Do entitlements actually work? And it turns out that most children are actually stably covered under Medicaid throughout these 4 waves of, this is approximately a 3-year period. These kids are usually stably covered under Medicaid. There is a small increase in private and federal insurance, which sort of tends to taper off there, and there is a steady reduction in the number of these children who are uninsured. But of course, these static pictures actually mark a whole range of underlying dynamic changes that goes on. And so we actually fitted growth mixture models, and we described 2 populations of children in child welfare. Those that we called the maintainers. These are kids for whom entry into child welfare system occurs perhaps with insurance coverage, and they maintain that coverage over time. And another group that we called the gainers, for whom entry into child welfare seems to act as an entry into Medicaid coverage. And we theorized that this is one mechanism by which child welfare systems seek to assure healthcare services for kids in the child welfare system. This is not what we expected to find. We actually expected to find declines in Medicaid coverage over time. But actually for child welfare populations at least, it suggests that entitlements are actually working. In fact, the problem occurs for kids who leave child welfare and then are no longer subject to a Medicaid entitlement. These are data published with Curtis Macmillan, where we actually show, this is a Missouri sample of about 400 and odd children leaving Missouri's foster care system, followed up for about 3 years. At every follow-up wave after departure, the cumulative proportion of these individuals who are uninsured rises. So at the first wave, less than 5% are uninsured. But by the time the 3rd year rolls around, over 30% of them become uninsured. And per wave, there's a steady increase in the numbers of children who actually fall off of insurance coverage over time. In fact, if you plot the hazard rates of insurance loss over time, this is what it looks like. And many authorities have talked about an insurance cliff, which actually happens when children transition from a child-based to an adult-based system of insurance coverage. And we actually show for at least kids in Missouri, this is what that insurance cliff looks like. But the problem, again, to reiterate, does not occur while kids are in welfare. It only seems to occur once they leave child welfare and begin the transition into the adult world. So at the end of this, I think the answer is that entitlements are working, and that if we manage to preserve Medicaid for children in child welfare, maintain all the eligibilities that they have, and maintain and strengthen Medicaid for these kids, we probably won't have much of a problem when it comes to access to services. This is not to say that there are no individual level determinants of access to services. Dr. Raghavan was talking about the fact that there are many providers who refuse to accept Medicaid. It's called Medicaid assignment, and they decline assignment into Medicaid. So there will always be these individual level or provider level determinants of care, but of access problems, barriers to access. But systemically, there doesn't seem to be a major problem when it comes to access to services. Which leads us to quality of care. Our quality challenges what is going on. The traditional way of looking at quality is to look at clinical appropriateness. So basically, especially those of you who are clinicians, if I say quality of care, you think of appropriateness. So if somebody shows up in an emergency department and clutches his chest and profusely sweats and complains of pain, and especially does a fist like this, is this person started off on aspirin? Does this person get a beta blocker? Presumptively, even before any tests have been run. In fact, that is a metric of quality in HEDIS, which is one of the quality measures. It turns out that for services researchers, it's really hard for us to think about clinical appropriateness as a yardstick of quality, primarily because we don't have access to clinical data. We haven't examined these patients. And so if I look at a prescribing pattern that suggests, and this is our data published in Missouri, that something like 18 children are taking 4 psychotropic medicines concurrently, 7 children are actually taking 5 psychotropic medicines concurrently, a pattern that is inconsistent with any practice guideline. Although this is worrisome, it suggests that we may be putting these children at risk for kidney disease or liver disease. It's not entirely sure if this is appropriate or inappropriate. because we don't really have the sort of clinical data that would allow us to prevent ourselves from second guessing, in effect, the treating physician. So clinical appropriateness is a really hard way to look at quality for services researchers.